Good morning, everyone, and welcome to the Rocky Mountain MS Center MS Summit. This is the 13th one we've had since 2014. We do these twice a year to hopefully bring to you newest information about MS and to answer as many questions as we can. This is a collaboration between the Rocky Mountain MS Center and the Rocky Mountain MS clinics at the University of Colorado Hospital. I'd like to take a second just to tell you a little bit about the Rocky Mountain MS Center and the Rocky Mountain MS clinic. We've been collaborating with each other since 2008. We've seen more than 4,000 distinct patients through the MS program. And we also collaborate in research and education. It's a very outstanding collaboration from my perspective because it helps us as physicians to reach a much larger patient population. Also, our program at the University of Colorado has continued to grow. There are now 9 neurologists, 2 fellows, and 3 advanced practitioners, all working together to provide care to MS and related diseases. It's been a remarkable journey for me and one that I hope will continue and be successful. For now, I'd like to move on and talk a little bit about a specific topic. So today, what I'd like to talk about is what is different about MS today versus in the past. And my major point here is that we have fundamentally come to a new era in the treatment of MS. MS is now one of the most treatable diseases that we see in neurology if we can catch it early before patients develop significant disability. It's also becoming quite treatable even in those patients who do have disability. So as an academic physician, I do work with companies to advise them and also to develop clinical research projects and other projects, and these are the people that I've worked with in the past year. So a few weeks ago, I was involved with a debate with Dr. Brian Weinshanker at Mayo Clinic. And Brian and I have done this debate several times at the American Academy of Neurology and other places. And basically, it's been a debate about whether the appropriate approach to multiple sclerosis treatment is to start out with the older first-line therapies and wait for patients to fail those before you move up to newer orals and ultimately the infusible drugs. That approach to MS is called escalation therapy. And it is the traditional approach for MS management around the world. However, I've been arguing for more than a decade now that the appropriate approach is to use the most effective therapies that we have that have an appropriate safety profile as early in the disease course as possible. And Brian framed this as the second statement: that highly effective therapy is indicated for all patients with MS from the time of diagnosis. That's not absolutely true, but I think it's pretty close. And I'm going to just briefly review the reasons why I think this is the appropriate way to go, and I'll give you some data suggesting that we actually can achieve this in this day and age. So the first thing is that it's very difficult in an individual patient as a clinician when you first see them to predict how they're going to be doing 10 years, 15 years, or 20 years down the road. And part of the problem is that of all the medications we have, the injectable and oral disease-modifying therapies, which means interferons, the glutaminyl acetates, Albagio, Gilenya, Tecfidera, et cetera, they all have variable efficacies. So they do decrease disease activity, but only partially. Some more than others, that's true. But again, there is significant ongoing disease activity in some patients. And secondly, we have no way of knowing how people are going to do over the course of the disease untreated, nor do we know how they're going to respond to any particular therapy. So there's no genetic factors that we can use to identify people at higher risk versus low risk. There is no initial presentation that predicts benign MS with high reliability. There are people who think they can identify such patients, but if you actually follow the patients they identify as benign MS for 10 years, more than half of them have gone on to develop moderate to severe disability. If you follow them for another 10 years, another half of them will have done that. That's not a very good predictor. Also, change over time in the MRI is not a very sensitive tool to actually measure the true level of disease. That's because most of the disease activity is in the site of old lesions, so it's not visible as a new spot on the MRI. Volumetric MRI, which we do use at the University of Colorado, is not accurate enough to help in prognostication. It's useful when you combine data from multiple patients. On the individual patient, the tool is fairly noisy, and so you can get change in volumes because they use a different MRI, it's a different magnetic field, or they change the software in the MRI unit. So at this time, we really can't use MRI to follow response to therapy very sensitively. We are working blood tests that may help us monitor disease activity. Neurofilament light, or NFL, is one of the most promising. However, it's not yet validated as a measure of neuronal death and as a monitor for disease response to various therapies. I hope that will change over the next couple of years, but we're probably at least 2 years away from having such a blood test in the clinic to be able to monitor how people are doing on different therapies. Also, just to point out to you that there are two different ways that patients end up in a wheelchair. One is because they have a lot of disease, which any neurologist can see, but the other one is they don't have very much disease, but they have it in a critical place, such as the cervical spinal cord. Those patients may have very little disease in their brain, which may be misinterpreted by clinicians as having benign disease. Because they have it in the cervical cord, and because MS plaques, once formed, tend to be the target of further episodes of inflammation, they can move downhill and end up in a wheelchair. And in fact, about a third of all patients in the wheelchair are there because of this reason. And the other problem with the concept of escalation therapy is that it's based on this concept that you start patients on modestly effective therapies, and then you wait for them to fail, which means wait for them to develop more disability before you consider moving up to the second tier drugs, which would be the orals, and then eventually up to the third tier drugs would be the infusibles. That's kind of letting the horse out of the barn, because we do not have a way to go back and repair the nervous system or to help patients recover function above what their brain can do on its own. And to just prove this point, this is an old study. It's back from the 1980s, before we had any treatments that were proven to be effective in MS. And it's a number of different studies. It's actually 4 different research groups looking at the natural history of multiple sclerosis in terms of what happened to people diagnosed with this. And if you look over at the left here, you're looking at 5 years from onset, 10 years from onset, and 15 years from onset. From onset here, it varies between the studies. In some studies, it's when the patient was diagnosed, which means patients have had disease substantially longer, because we don't diagnose people at the very beginning of the disease. In others, it is with their first clinical symptom, which is still relatively late, since most MS disease activity is clinically silent, and patients have already accumulated significant brain lesions prior to the first relapse in most cases. But if you look at this, they defined patients as having an EDSS, or in this case called the Kursky Disability Status Score, of 3 or less as moderate disability. And between 70 and 80% of patients at all these time points have already achieved that. And that means that they may be able to walk okay, but they're going to have disabling fatigue, cognitive problems, depression, bladder problems, neuropathic pain, spasticity. And that was defined by Dr. Weinschenker in his early papers as the definition of benign MS. I would argue that's not very benign. And then out here, we're looking at an EDSS of 6, which means people have to use a cane or more for ambulation. And by 5 years, somewhere between 8 and 40% have already achieved that. And by 15 years, it's 40 to 80% of patients have achieved that. An EDSS of 8 means patients are bedridden, not able to provide care to themselves. And the chance of that within 15 years of onset is between 8 and 30%, depending on which study you look at. And this is at mean age of 45, because the age of onset of MS is age 30. So this is still very early in life. And I would say that these are not desirable outcomes by any stretch of the imagination. I would argue that today our goal is much different. So this is the disability status scale developed by Dr. Kursky. And 0 means you're basically healthy, you have no symptoms. 1 means you might have some minor symptoms, some minor fatigue, maybe some numbness and tingling, maybe had absolute blurred vision, but you're able to function fully. 2 means now you're getting some minor disabilities, so you're not able to do all the things that you'd like to do, again, usually because of fatigue or pain or depression or those kind of symptoms. And then out here, 3, moderate disability, where you have severe pain, you can have severe cognitive function, you have severe disabling fatigue. And by 4, it means that now you also have these other symptoms, but you can't walk normally. So you can still walk more than 500 feet, but you can't walk the way you could before, you probably can't run. And it just gets worse thereafter. So the folks that argue for escalation therapy would argue that if you stay below an EDSS of 3, they still consider you to have benign MS. And these patients, already about half of them who were working in the workforce, are now not working because of MS. That's not an acceptable goal. I would argue that our goal is a zero, EDSS of 0. And I'm going to show you that we have actual evidence that we can achieve that today in early phase disease. So in order to understand that, I just want to briefly review what I've talked about before, which is the concept of neurologic reserve and its implications for the treatment of MS, and the concept of maximizing lifelong brain health. And again, I'm not going to go into this detail. So remember, as I've discussed before, that the natural history of the human brain, not the MS brain, but the human brain, is one that goes like this. We're born with pretty much all the nerve cells that we're ever going to have. We can make a few nerve cells in a few small areas, but by and large, bulk of our neurological function is based on how many nerve cells we have when we're born. Our brain expands in size from birth to about age 20 because those nerve cells are connecting themselves into these large synaptic networks, and the other cells, the oligodendrocytes and the astrocytes that support them, are proliferating. Brain volumes, which reflect the number of neurons you have, are stable between age 20 and about age 35. But by age 35, all of us begin to have a loss of neurons. It seems to be genetically determined. It's not fully understood yet, but it is normal. And we begin to lose neurons, but yet we're able to maintain normal neurological function. And that ability to maintain neurological function when we're losing neurons is due to the fact that we have excess or reserve capacity in the brain that allows the brain to shift function around and to maintain normal function. And that's enhanced if you're exercising and if you're avoiding diet-related diseases like hypertension and diabetes. So that's what happens to all of us. What happens on top of that to MS patients is that MS is using up that neurologic reserve. So neurologic reserve in MS, again, is the capacity of the brain to compensate for subclinical MS disease and to recover from relapses. Again, neurologic reserve is also there for normal aging. But the reserve capacity buffers early MS activity to decrease the impact on motor function, cognitive function, and sensory function. Now remember, the average age of clinical onset for MS is age 29 to 30. But we think most patients begin to develop the disease in late teens and early 20s. Whereas aging effects are not seen until the 30s or 40s. So MS is occurring in early life, is accelerating the loss of this neurologic reserve, which will come back to haunt us in two different ways in the future, which I'll come to. But because of neurological reserve, the diagnosis of MS is often delayed. 90% of MS disease activity in the brain is clinically silent, so the patient doesn't know that it's going on because it's being masked by this neurological reserve, but the reserve is being consumed. And when progressive disability sets in, so secondary progressive or primary progressive disease, we see continued loss of function in cognitive function and motor function, and that correlates with neurological reserve. Now, there's another concept in neurology, which is neurological resilience, and that's the ability of the brain to recover function. Neurological reserve and neurological resilience are the same biological phenomenon. We're just talking about subclinical brain injury with reserve. We're talking about overt injury with symptoms of neurological resilience. And the other problem is when you use up neurological reserve, you've also used up neurological resilience, which means if you start to treat at that time, you may slow things down, but you're not likely to get a lot of recovery of function. Some basic natural history issues for MS that we all need to understand. One is that most of the inflammatory disease occurs at the beginning of the disease. So the disease is most active at the very beginning, and that activity gradually decreases as a function of age. It is the inflammatory disease that drives the loss of brain volume, and I'll show you data to support that. So there are people that argue MS is two diseases. It's a neurodegenerative disease and an inflammatory disease. In reality, it is an inflammatory disease that drives neurodegeneration. So if you shut off the inflammatory disease, you can dramatically impact that neurodegeneration. Whether you can stop it completely or not in progressive disease is not known, but our clinical data says we can stop it completely in relapsing forms of MS. And I would argue that the onset of progressive disease is mostly due to this exhaustion of neurological reserve, and that onset of progressive MS fundamentally changes response to MS, mainly because of that neurological resilience issue that I mentioned, that in relapsing-remitting disease, people get better over time on average, whereas progressive disease, we slow things down rather dramatically, but we don't get as much recovery of function. And this is the data to show you that most of the cause of loss of neurons is due to inflammation. So this is measuring brain volume in patients over 18 months. And here they're getting monthly MRIs for the first 6 months of the study. And the plot here is plotting how many active lesions they have on those brain MRIs over 6 months, and then what's their rate of progression of their brain atrophy, which is a reflection of loss of neurons. And you can see the patients out here that have more loss of neurons out here have a much faster rate, up to 2.5% loss of brain volume, which bodes poorly for future disability. These numbers up here are called R values, but they basically tell you what percentage of this loss of brain volume is explained by just this observation of how many active lesions people had over that 6 months. And what this basically means is that of all the factors that affect loss of brain volume, number of new lesions represents 75% of that. So to think about that, if you have 10 people rolling a big rock up a hill, in this situation, one of them is providing 75% of the horsepower to do that, which means you take that one person out and the rock rolls over everybody else. And that would mean here, if we could stop this part, 75% of the factors driving brain volume loss would be stopped. And that's really important. If you do it by volume, it's actually 85%. So to take a little bit further to help you understand a little bit more about why brain volume is so important and why preserving an early disease is so important, is, as I said, we all lose brain volume later in life. So the red bars here represent all of us patients, all of us people who do not have MS. So I'm in the red bar. This is what's happening to my brain volume over time. And frankly, I'm right out here. So I'm losing about 0.3% of my brain volume per year just because I'm over the age of 60. If you look at the total brain volume loss in MS patients over time, you see that the amount that's being caused by just normal aging, which is not treatable at this point, is increasing steadily. So if you want to preserve brain volume, starting at the beginning of the disease, back here at age 30, is where you want to use anti-inflammatory therapies, because most of the brain volume loss here is due to inflammation. And if you shut that off, your brain volume loss goes from 0.4% per year to way less than 0.1% per year. And then that helps preserve brain to compensate for out here. It's true for other parts of the brain as well. So to summarize this part, here, the main thing here, what I'm trying to contrast is what happens to the normal healthy brain, which is here in this blue line. So it's pretty stable until you get into your 30s and 40s, and then we all begin to lose brain volume. But in multiple sclerosis, because of these inflammatory events, which manifest as relapses and as new lesions on the MRI, our brain is shrinking at an accelerated rate. And that continues throughout the course of the disease and adds on to what's happening with normal aging. And it's also important, as I mentioned, that most of the disease activity is subclinical. So these are MRI lesions, and these are relapses. And the ratio is about 10 to 1. And so most of the disease is subclinical. It's like hardening of the arteries. You don't know that it occurs until you have a critical event. And what I've told you is that the brain reaches a critical point where it moves from relapsing remitting into secondary progressive MS. And that's because, I would argue, is because loss of neurological reserve. And after that, if you allow that to happen, you're now stuck with the problems that you have a smaller brain, which we can't change right now. And so if you stop the inflammatory disease, these relapses and stuff here, you can definitely slow down disability progression, but you can't stop the normal effect of aging on that as well. So again, we want to avoid this cliff as much as we can by treating as effective as we can back here at the very beginning of the disease. And if we do that, then this line can disappear and patients will follow this line, the normal healthy brain line, which is what we want to do. And again, just remind you that the inflammatory attack on the brain is steadily decreasing as we get older. So if we can control the disease for the first 20 or 30 years, they may not need any disease-modifying therapies after that. So when I argue highly effective therapy should be used for all MS patients at the time of diagnosis, that doesn't mean all highly effective therapies. And this is where a lot of physicians get confused, because we have highly effective therapies that are very dangerous. So let me tell you what I mean by that. Highly effective therapies are primarily the infusible drugs, Tysabri, Rituxan, Ocrevus, and the newest drug is Kesimpta. These are all monoclonal antibodies, and they work by targeting either proteins involved in allowing lymphocytes to migrate into the brain, or by killing B cells in the circulation. These therapies tend to decrease disease activity in terms of relapses by 80% or more and they decrease MRI disease activity by 95% or more. Second line drugs are mostly the orals. And they're second line for two reasons. One is they're less effective at preventing inflammation. So they're in the 50 to 60% range in terms of relapses, and maybe 70, 80% range in terms of MRI. But they also have more side effects. So the fingolimod or gelenium, mayzin, and ziposium are S1P receptor antagonists, and they have more off-target effects. They can affect the heart, the lung, the retina of the eye, potentially the liver. They do increase your risk of infection, as these drugs up here might as well. But these drugs don't have any particular effects on off-target effects like on the heart, lungs, or the organs. So even though these oral drugs are good therapies, they're just not as easy to use, not as well tolerated, not as effective as these, and they're not particularly safer than these therapies used in the appropriate patient. The third line drugs are the drugs that are down in the 30% range in terms of relapse rate reduction. And these include albagio and all of the injectable drugs, the interferons and the tumor acetates. And these drugs, we believe, are third line because they do not prevent people from moving into that progressive disease, because they're only preventing a minority of the total disease activity. And so the brain volume loss is continuing pretty much unabated in these patients. And then the fourth line therapies can be considered highly effective therapies, but there's no evidence they're more effective than these therapies, but they have a much higher risk. So Tysabri in patients positive with JC virus is a dangerous drug, and would only be used in our clinic as a last resort. Alemtuzumab or Lemtrada, cladribine, and stem cell transplant are all the same. Again, they may be effective. They're not necessarily more effective than these, but they do have risks of cancer, serious infections, autoimmune diseases. So because of the risk profile, these are rescue drugs that you would only use if all these other drugs have failed. A little bit of evidence that these drugs are not created equal. There's actually quite a few papers, more than 15 papers in the literature now, that have been done in the real world to demonstrate that the oral drugs, the injectable drugs, and infusible drugs are really different in the way that they impact disease activity. This happens to be from our group, published by a first author called Brandy Vollmer. And basically she's an epidemiologist and did a lot of chart reviews and looked at 1,000 patients roughly. And basically what she showed is that patients that were treated with gelenium, which is F2I, or Tecfidera, which is DMF, had more disease activity as measured by new MRI lesions, relapses, or progression of disability than people who were on either rituximab or Tysabri. So this is the Tysabri line, this is the rituximab line. These lines are not statistically different. So based on this analysis, these two drugs are essentially equivalent. These two drugs are equivalent to each other, which is Tecfidera and gelenium. But there's a clear statistically significant difference between outcomes at 2 years. And this outcome grows continuously after that. That's been demonstrated by the European database group, as well as Canadians, as well as the Swedes. And I'm going to end here at this part of the study or discussion by telling you about a recent study that's still in progress, but is showing us just how close we can get to full disease remission if we treat early enough. So this is called the Ensemble Study. It was done by Genentech. It's a study I recommended to them about 4 years ago to do based on our experience in the clinic, that if we treated patients when they were first diagnosed, it was very common for them to come back at 1 to 2 years and tell us they didn't feel like they had multiple sclerosis anymore. So in this study is done with people who have relapsing remitting MS. So they've had at least a clinical relapse and at least a separate new lesion on MRI that was active. The age of these patients, the mean age of the population is only 32. As I told you, the mean age of onset of the disease is age 30. So these are very early disease patients. Again, predominantly women, which is typical for MS. 3D scores were quite low, as 1.7, which means that they can have fatigue, pain, bladder problems, but they're walking normally and they're able to work. And ones that had ESS less than 2.5 is the majority of 75%. Their duration of symptoms was about a year, but the duration of their diagnosis is only about 4 months. So again, this is very early stage disease, but they're very active. They're having 1.3 relapses per patient per year, which is a high rate. And if you look down here, about 30% of the patients had more than 2 relapses in the prior 2 years. And it's about 5 months since their last relapse. So in coming into this study, they had to have evidence of active disease, and they did that by having a relapse or having a new MRI lesion, or having both a relapse and a new MRI lesion, which was the most common group. So again, a young, very early phase disease group of patients that have very active disease. And this is the key result. So this is what's called no evidence of disease activity, or NEDA. It's a term that we use in clinical research with MS to look at outcomes of various clinical trials. It's usually not the first outcome we look at because the FDA still prefers relapse rates or disability progression. But this is really the important outcome. This is telling you about how many people had no evidence of any disease activity. It means they had no relapse, they had no new MRI lesions, they had no gadolinium enhancing MRI lesions, and they had no change in their ability to walk on 24-foot or the 25-foot walk. So the percent of patients that ended up with no relapses was 98%. That's remarkable in this very active group. This is in the first year, this is 1 year data. And 94% had no MRI disease activity in terms of new lesions that were contrast enhancing. 95% had no lesions, including no T2 lesions, which means it's an older lesion that happened sometime between there and baseline. And 94% had no change in ability to walk. This is kind of a messy number because this is not a very reproducible scale, but having 94% not having had any decrease is remarkable. And if you combine all of those together, no evidence of any clinical activity occurred at 93%, no evidence of MRI disease activity 91%. And because those are different patients, the overall score for NEDA is 85%. That is remarkable. That's not what we see on the injectables or oral medications. And this data is now being tabulated for year 2. It looks very similar. This is a 5-year study, which is really important because that's the point we were trying to make, is that if you intervene early, you can maintain people with no evidence of disease activity for long periods of time. And in my experience clinically, I'm out 10, 12 years, and patients are still stable the way they were before. Also, they looked at biomarkers and what happened to them. So here we're looking at neurofilament light, which all of you have heard about in the literature as an evolving blood test that we might be able to use to monitor what's going on in the brain. And at baseline, you can see that if patients had a relapse or an active MRI at baseline, they have really substantial elevations in their neurofilament light. If they were basically without disease activity at the first beginning, they hadn't had a relapse within 3 months, and MRI was normal in 3 months, then they had a little bit lower levels of NFL. So NFL correlates with active disease. And remember, active disease is a pulse of inflammation that causes damage, which will then resolve over 2 or 3 months. And then there'll be some time later, people get another pulse of inflammation. And then the gray is the healthy controls. And what you can see here is that week 96, which is 2 years, the NFL levels in the blood in basically all groups have been normalized. They're basically the same. And that is remarkable. This is the primary progressive study, the oratorio study. So again, at baseline, majority of patients had elevated NFL levels. And again, at 2 years, they were moving back to normalized. They have not normalized completely here. And again, I think this is the fundamental issue for progressive patients, that the ocrelizumab and other highly effective therapies can shut off the attack by the B lymphocytes. But probably by that time, patients have developed another inflammatory process that's going on inside the blood-brain barrier that we have not completely shut off. And this is what we need to target in future studies. So this is telling us something important. Also, one final point on this. This is looking at brain volume, but you could do the same thing if you plotted disability levels or probability of progressing to sustained disability. And that is that there's a clear treatment effect of the ocrelizumab versus, in this case, Rebif over the first 2 years of the study. So the patients with ocrelizumab have a substantially lower chance of having a change in brain volume in this study or change in disability. Once you start them on ocrelizumab, which occurred at the end of year 2, they also get a treatment effect where this loss of brain volume slows down, and it parallels what's going on in the always treated group, but you see it never catches up. So on the escalation therapy concept, you allow patients to accumulate injury that even when you do switch them to highly effective therapy, they never overcome. They've now paid a price that they're going to pay for the rest of their life. And this is one of the strongest arguments to start with highly effective therapies rather than wasting time on modestly effective therapies. And there's just to finish up then, just to update you a little bit with the astrocytes. I've discussed these before. So astrocytes is a key cell in the brain. It makes up about half the volume of the brain. And it's there to protect the neurons and the oligodendrocytes and to feed them and to remove toxic metabolites and to regulate the transmitters and things that are being transmitted. So without astrocytes, you can't have neurons or oligodendrocyte be alive and function. Astrocytes are key to maintaining that special environment in the brain to allow these to work. And there's already data that most of the world is not aware of, that astrocytes actually could be the initial target of multiple sclerosis and the cause of the loss of oligodendrocytes and neurons over time. So astrocytes do a lot of different things. They are an extremely versatile cell, and this is not all of them. This is just what they do related to producing cytokines, which are short-acting hormones that are either pro-inflammatory or neuroprotective. And they don't do all these at one time. So astrocytes are sort of, in football, you have people who can play any position. Astrocytes can play any position. And they do that by getting pushed in one direction or another by other factors and other stimuli that come from other cells. In multiple sclerosis, they're mostly acting like these pro-inflammatory astrocytes. They're acting as part of the immune system, and they're producing molecules like nitric oxide and tumor necrosis factor that are toxic to neurons and oligodendrocytes, and we think actually play a major role in the death of oligos and neurons. And these other immune cytokines activate the rest of the immune system. They help promote the inflammatory attack on the brain. They support B lymphocytes as well as T cells in their attack on the nervous system. However, they can be pushed into a direction where they stop doing this activity, but they do more of this, which is neuroprotective. And when they produce IL-10, BDNF, CNTF, and other nerve growth factors, they encourage neurons to put out new branches and rewire and connect. They encourage oligodendrocytes to put out new branches and remyelinate. And they can change the nature of the MS plaque to make it easier for neurons and oligos to do that. So targeting astrocytes therapeutically is very important because we could inhibit this pro-inflammatory role that they play, and we could promote this neuroprotective, neurorepair role that they have. And this has been demonstrated already. FTY720 is gilenia, and it works through astrocytes. The data is very good. This does not work on the peripheral immune system. It works at astrocytes. It works by inhibiting this pro-inflammatory signaling pathway called the NF-kappa B pathway. Also, this pathway is inhibited by Tecfidera. DMF is Tecfidera, and that also inhibits this. And Tecfidera also increases the regulation of a pathway called NRF2 or NRF2, which is a pathway that decreases the production of nitric oxide and helps buffer for that. And again, nitric oxide, we think, is playing an important role in damaging neurons and oligodendrocytes. There are many other drugs that can play a role in this. And one of the most attractive ones to me recently has been Metformin. Metformin is a drug used to treat type 2 diabetes. A lot of MS patients take this because they have type 2 diabetes. But this drug appears to induce recovery of function and neuroprotection in many different diseases, not just MS. Also, Abutulast is hopefully going to go on trial and has already demonstrated that it can preserve neurons. Whether it can improve clinical outcomes remains to be proven. And then there's a whole bunch of other drugs over here that are potentially in that category, including a new monoclonal antibody that is currently in phase 2. So in conclusion, I would argue that escalation therapies are no longer justified, that we can use the most effective therapies that we have in a safe way if we carefully select the drug and carefully select the patient and monitor the patients carefully for safety. And also that highly effective therapies indicated for almost all MS patients at the beginning. There are a few that might have a particularly benign disease. They may have one lesion or something and the course is not quite clear, that we may want to follow off therapy. But in general, if patients have evidence that their disease is slightly below average to average or above average, they should be on one of these therapies. And we have a wide variety of therapies, so we can usually find at least one of the therapies that's safe for a patient based on their particular biology and comorbidities. And finally, that's the most exciting area for us working in now is now beginning to develop these add-on studies for neurorepair and neuroprotection. Our personal goal is to get Metformin study going where it would be added on to the infusible drugs for patients that are stable but still have elevated levels of NFL and still have significant disability, to see whether we can help them recover more function. And that's what we're focusing on this next year. So again, treatment of MS is in a totally new era where this is an incredibly treatable disease if we just approach it with the therapies that we have in the optimal fashion. Thank you very much.